The primary failure during COVID, the failure to recognize the 10,000-fold risk difference between an older individual and a young, healthy child. And so these blanket policies started suffocating, turned into a second pandemic formed during COVID pandemic, which I call the pandemic of lunacy. And of course, the greatest irony is that during that time, they were leading a massive cover-up of the COVID origins and the embarrassing fact that the United States government was funding that very lab, while the rest of us were trying to figure out what COVID was about and the risk.
Hi, Dr. Marty.
Hi, Tammy. Good to see you.
We had a good meeting at a dinner for the, now what was that called? It was with a senator that had brought a bunch of specialists together to talk about trouble in medicine.
Yeah, the Senate Roundtable on health and Make America Healthy Again.
Yeah, and RFK was there, and it was, well, I've spent my whole life wondering what was wrong in my health and in other people's health, and so it really does come as a very good feeling that people are paying attention to that. And you've written a book on the history of medicine and the blind spots that you've found. Do you have a copy there?
This is the other book. This is the prior book, but let me.
I have it right here. I can show it.
Yeah, I don't have it with me.
I have it.
Gave away
Blind spots.
There you go.
I read it a couple of times. It's a very good book. It's really interesting because if you like history, it's interesting because there's a lot of history in it. And if you're interested in how things have developed in the medical field, that really gives you a pretty good historical story about why we are where we are now. So I'd like to talk a little bit about the history, and I'd like to talk about where we are now in comparison to where we were and why things are the way they are, if that sounds like a reasonable story trajectory. I don't know.
That sounds great. I think we were having dinner the week it came out, and we didn't know how the book was going to do, but it's had 5 weeks on the New York Times bestseller list.
Oh, congratulations.
Thanks,
Tammy. Yeah, no, I thought, I don't read, I mean, I do read quite a bit. And some books I get through, but this one I read twice. I liked it a lot. Well, there's a lot in it. So the first time I read through to read the story, but the second time I read through to make sure I didn't miss anything because there was a lot there. So, and I wrote down lots of things, but there's so much that I think we'll just talk about it because there's just so much there. Women's health, men's health, it's everything. So so I'm just going to tell everybody, you're a distinguished professor at Johns Hopkins University School of Medicine. And so you've been looking at, you were tweaked for some reason. Let's have you answer this first. Why did you go about to find out what was wrong in the medical system really early on in your career?
Well, I think any intellectually curious person who goes through this incredible and intense medical training can tell that something's wrong, that we're missing something big. And you naturally have this curiosity and this objection to say, hey, wait a minute, why? Why is the average age of puberty going down by years from what it was a century ago? Why are sperm counts going down by 50%? Why are half of our nation's children obese, and it wasn't that case just a generation ago or in Japan or other countries? And this natural curiosity that we have really gets squashed by the culture of obedience in medical school. And it's not diabolical. Nobody wishes illness on anybody. It's just that we have our traditions and our priesthood and our loyalties and our customs. Mm-hmm. And part of that is this culture of memorize and regurgitate. And then when you come out in training, it is focused on billing and coding, and we measure doctors by their throughput. And so we never ask these big questions sometimes. no, sometimes the most important questions in all of health are in our blind spots. And so the reason I wrote this book is that, and the reason to write any book, as you know, is because if you feel that there is a very important topic that is not being discussed, that needs to be discussed badly, and you have a vantage point on it, you almost feel a moral duty to spread the word.
Mm-hmm. Mm-hmm. And I wonder, I know that I've held doctors in very high regard. Well, always. And some of that can blind us ourselves into the questions that we need to ask, because following blindly is not a good idea. You should always be asking, does this make sense? Is there a better way? Have we looked at alternative ways to treat this problem that I'm facing? And so all those questions should be at hand, but they're not. We just say, okay, whatever you say, I'll do it. And we hope that is the best. But now you're saying, well, might be the best, but might not be the best. So
yeah, the white coat era of medicine is a fascinating phenomena in modern society. Mm-hmm. Doctors were always respected, but not held on this intense pedestal historically. For most of human history, doctors were respected, but maybe like you would respect other people in society that did a good job, your hairdresser, a barber. But then and we didn't have many tools as doctors. We had a saw and an axe to do amputations. We had a lancet to make you bleed to try to remove the bad humors. And we had one or two crappy medications like digoxin that didn't really work. So we didn't really have much. It was a very primitive sort of understanding of health. And ironically, there were low rates of some of the chronic diseases that are high today back then. But then in the age of World War II, there was the mass production of antibiotics. And so coming out of World War II in the post-World War II era ushered in the white coat era of medicine. Doctors now had the power to control a magical pill that could cure you, that could enable women to deliver babies safer, that could enable surgeons to do incredible operations without the risk of postoperative death from infection, that could cure a child of an ear infection. A kid could, in the old days, die from a scratch on a tree if a bacteria would just work unopposed and take their life. And so for the first time, we now had this magical power, and we controlled the administration of antibiotics. And doctors began to have technology in the hospital, an iron lung machine for polio patients and incubators for babies. And people were amazed at the medical profession. And it was a priesthood. You had to go to certain universities, even though those universities didn't teach pre-med education. It was a lineage of sort of an elite ruling class. And doctors got this unquestioned authority, and they began to abuse it, probably unintentionally. Mm-hmm. Keeping babies in the hospital for 10 days routinely, even though the baby's totally normal.
You said preemies they didn't treat them well at all.
No, they starved preemies. They would decide which ones to try to resuscitate and not. They would not show the preemie to the mother in case the baby didn't survive. They thought, well, we don't want them to be traumatized by seeing their children. This intense abuse, and the pendulum really swang far in one extreme. And we're still reeling in from that now, trying to find a balance between modern medicine and restoring ancient natural principles of health.
Right. Yeah. Antibiotics must have been something. And the beginning of the vaccine, that story was very, very interesting. The farmer who noticed his milkmaids weren't getting sick with smallpox.
Yeah. The milkmaids who were well known to get cowpox virus.
Cowpox, that was it, yeah.
Were not getting smallpox. Uh-huh. And so he observed this sort of cross immunity. So when they noticed that the milkmaids were not getting smallpox, because it was well known they were often infected with cowpox, it created this concept in their mind of, natural immunity to smallpox or immunity. And so the cowpox it's a mild infection. The cowpox virus particles became the world's first vaccine against smallpox, basically giving people that cross immunity.
Yeah.
And President Thomas Jefferson, I think it was President John Adams, was proposed the idea of a national vaccine institute to get this vaccine out there in the United States, this cowpox vaccine. He didn't really act on it. We don't know why, but then Thomas Jefferson decided to run with it and created really the first national vaccination effort.
And when we look at it, you said that COVID, there was 0.1% of people were killed by COVID. But smallpox was a huge problem. It was 20 to 50% of the population?
Some populations. So I don't mean in any way or intend to downplay the tragedy of COVID.
Well, it's tragic on an individual basis for sure, but in terms of the population, quite a difference.
In terms of how lucky we got during that pandemic, the overall infection fatality rate was somewhere around 0.1%. There are viruses out there with a 20% infection fatality rate. Now, luckily, they have not been super highly contagious in a pre-symptomatic state of the body where you don't know you're sick, but you're spreading it. Mm-hmm. But, in the world of global pandemics, we are lucky that it was not 1% or 10%.
Mm-hmm. Right. And look at but it was such an over response. It was overly, it was definitely over the top. The response.
The primary failure during COVID was the failure to recognize the 10,000-fold risk difference between an older individual and a young, healthy child. Mm-hmm. And so these blanket policies started suffocating the lowest risk population. And it became, it turned into a second pandemic formed during COVID pandemic, which I call the pandemic of lunacy. Mm-hmm. Fauci was telling teachers in July of 2020, 6 months into the pandemic, to wear goggles and gloves in the classroom if they really want to lower their COVID. Now, he could have done the experiment in the lab to know that it's not spread from contact with your eyes. You don't have to wear side shields on your glasses. But he thought he'd rather opine on it. And of course, the greatest irony is that during that time, they were leading a massive cover-up of the COVID origins and the embarrassing fact that the United States government was funding that very lab while the rest of us were trying to figure out what COVID was about and the risk. There's a film that I sat for. I'm in there for maybe 15 seconds, but it's a very well done film for an hour and a half, a documentary film about Dr. Fauci and the origins of COVID, the greatest industrial accident in the history of humanity, killing 20 million plus people. It's called Thank You, Dr. Fauci, and people can look it up at thankyouDrFauciMovie.com. I thought the producer did an amazing job, and it's very nonpartisan.
Mm-hmm. Oh, well, that's good. Yeah, well, I was thinking back, my daughter was 17, 16, something like that when the SARS virus came through. And Michaela. And she had a fever. She came upstairs one night saying that the Mona Lisa in the hallway was glowing or something. We had no Mona Lisa, we were like, oh, she's got a fever. And they thought she had SARS for sure. So I was in the hospital with her, and all of the nurses and doctors had hazmat suits on, like complete suits on. And if you came up to a desk, the person who was serving you would stand 6 feet back and talk to you. They wouldn't come up and talk to you. It was empty. It was empty. And it wasn't just empty. When I went to pay my parking stub, there was no money in the Instabank machine in the hospital because the bank people wouldn't come in the hospital to replenish the bank machine. And I should have known that it was just going to get worse. because that was the beginning of, that was like a sign, right? It was a sign, something has gone astray. We've just gone wild. Of course, she didn't have COVID. She had pneumonia because she was on immune suppressants, and she got pneumonia quite a few times while she was on these immune suppressants, which she finally got off of when she changed her diet.
Yeah, I remember.
Thank goodness, because that was not going to end well. That whole stream of medical intervention was not going to go well, And I told them, when she was 6 or 7, that oranges made her toes swell, and they didn't say, that's interesting. No, I knew it was food, but I just didn't know it was so extensive. I couldn't figure out what it was because everything seemed to make her sick. When I had her food sensitivity testing done, everything was red on the panel. And we were like, what? Everything? Yep. Yeah, everything. Oh, surprise. Yeah.
She had a powerful testimony that everybody should watch at the Senate Roundtable on Nutrition. I thought it was amazing. I got to know her background and spoke with her about it, and I was fascinated. And I'm embarrassed to say I know the medical culture. I know how they would respond if you say oranges make someone's feet swell. It doesn't fit their mindset. It doesn't fit their coding, billing system in medicine, right? Having a bucket for every little thing. And so if there's no randomized, controlled, long-term study, then they just dismiss a lot of things.
Yeah.
The randomized
my husband was trained as a clinical psychologist. He has a PhD. When I came to him with those kind of things, that's what he would say. It's not a randomized. It's not. There was no randomized study here. It's anecdotal. He'd have these things to say, and he would dismiss it. And it's no wonder, because you can't listen to everything. And so it is. I didn't have enough evidence. To have a compelling case.
Of course, the irony is no one's funding that research, and it's expensive and hard to do. So, no one's funding it, and there's no evidence. Of course, there's not going to, be a compelling case. But the absence of evidence is not evidence of absence. That is, you can't say there's no evidence, therefore it's not true. The real smart way to think of it is there's no evidence, therefore it is a scientific unknown, which means it may be true or it may not be true. And we have to be open-minded in medicine, in life, and humans need to be open-minded. And we need to recognize that we've got blind spots, and 100% of closed-minded people perceive that they are open-minded. It's more convenient, to be honest with you, Tammy. I think, I'm thinking from the trenches, because I've been in that situation in points in my career. We're busy. And so if you can dismiss hard problems and complex issues by simply saying, well, there's no randomized control trial evidence, therefore just dismiss it and get back to the real stuff, the hard science. It is convenient. And I think it's also part of our culture now. Do we need can we learn through other methodologies besides a randomized control trial? I can tell you, if I have a patient and I tell them you have cancer, they're not asking, what do the randomized control trials show on the median survival benefit of chemo drug A versus B? What they're asking is, what are the chances of a cure? And then how do I get a cure? And so we had a case of a stage 4 glioblastoma multiforme. This is considered an incurable brain cancer many years ago. And there's a guy who beat the odds and survived long term. And it's not because they got the pathology diagnosis wrong. This case has been reviewed multiple times. It is, in fact, the type of cancer that is known to be incurable. And what they recognized is that this guy was an outlier statistically. Well, what happened in his case? What did he do? It turns out that in his case, kind of curiously, after they resected the brain tumor a long time ago, over a decade ago, the records show that there was an infection in the tumor resection bed, and they went back to surgery and relieved the bacteria causing the infection, removed a bone plate, and then put the bone plate back on in a two-step procedure. And I don't know what happened there. It might have been physiologic, it might have been semi-physiologic and magical, but maybe the bacteria stimulated the immune system to respond to that tumor bed differently. Maybe the bacteria killed some of the tumor cells. Maybe it promoted mediators, molecules that were secreted in that area. I don't know. But that is far more fascinating and relevant than looking at chemo A versus chemo B having a 1 or 2 month survival difference. So we can learn from outliers, not just randomized controlled trials.
I see. Yeah, well, that takes me back to my experience, right, in the hospital, where the night before I was going to go in for this second surgery because they realized that what I had was going to kill me within the year. And I went back to a meditation that I'd done when I was 26, and I'd had a diagnosis of cancer without a biopsy. So they were guessing, and they told me, which was not a good thing. But I was taking massage therapy at the time, and I had a fellow who was working in Florida, in Key West, where all the people who were fat would go to lose weight. And he was working there doing massage therapy, and then he moved up to Ottawa, and I was finishing my degree in kinesiology, and I wanted to learn massage. So I took courses from him, 10 courses. And in this time, I was diagnosed with this problem. And so I asked him if he had anything he could do to relax me, because I was very, very nervous. And so he did this meditation that I now did with my husband the night before my surgery. And I imagined that I had all the people, because lots of people send me prayers, and my sister-in-law had put them all up on my walls. And so I had all these prayers. And so I lined all these people, imaginary people, up on a beach, and I breathed in all their prayers, and I took them down to where the cancer was, and I asked my body to tell me what was wrong. Just tell me what was wrong. And the cells looked like there was no way they were going to talk to me. They were turned away. This was cancer, and it was something that I couldn't communicate with. Like I had when I was 26, I'd communicated with my ovary had a cyst on it, a dermoid cyst. That's why they thought it was cancer, because it was a solid cyst. So when they looked at it through the ultrasound, they thought, oh, that's cancer because it's solid, but it wasn't. It was a dermoid cyst, and it just wasn't water filled. But I had done a meditation, and I'd asked what was wrong there. And I felt something leave the side of my body during that meditation. And they had told me that I had something the size of a grapefruit. When they took it out, it was something the size of a golf ball. So did some spirit leave or something? Like, I don't know, right? And nobody knows. And it wasn't cancerous. So that was all good. But this time it was cancer, and I couldn't see it. And I said, oh, well, this is too much for me. I have to give it back to the universe. So I just gave it back to the universe because it was too much for me. And when I went into surgery the next morning, I told them what I did. I told the doctors and the people all in the surgical room that I had done this meditation, and I'd breathed in all this love and attention. And so that's what they did. They said that's what they did. They told me that later. So that's what we decided to do in the surgical room. This was an intention of love, and we were going to do what we could with this intention of love to bring healing. And they took the cancer out, and they were successful. I just had I had a leak in my lymph system that nearly killed me after that. But that also healed miraculously. I'd told Jordan that I was going to be well on our anniversary in August. I told him that in June, and it was on that day in August that everything reconciled, and I was let out of the hospital on that day. So yeah, so I don't know, right? That's not very medical. That's not a very medical story, but it was medical. It was physical, but it wasn't just physical, because we don't live in just a physical world, right? We live in a physical, psychological, spiritual world. And it's complicated. And I think we've maybe tried to simplify that down to the physical. And so we're missing things. So we miss signs of what's there if we get too reductionist. I don't know. What do you think of that? That's a wild story.
We are missing things. We are missing things. I mean,
we're missing things.
The Massachusetts General Hospital, one of Harvard's hospitals, did a trial of patients with lung cancer, and they randomized them to different arms. One of them was chemotherapy, and another was supportive care with no chemotherapy.
Mm.
The supportive care arm lived longer.
Oh, wow.
Right? And it wasn't an experimental chemo where they were wondering if it works. This was a known chemo regimen that was believed to improve survival, and that's why it's broadly recommended. But they were kind of, surprised that, what is this? Actually, supporting someone and encouraging them and keeping them active and healthy and positive and in community and strong relationships. And it really kind of threw the medical field in a tailspin. And I think there was a little bit of discussion about it at the time, and then it was just dismissed. And we do get these studies every now and then that kind of rock the field of medicine. And we don't know how to interpret the results, right? Don't know what to do with it. The atrazine frog study, the second most common pesticide in the United States, converts a male frog to a female frog in 10% of the tadpoles that were exposed to it. A genetically male frog developing as a female, even growing eggs. What do you do? What do we do with that? Atrazine is in everything. I mean, these chemicals are showing up in the urine of children routinely.
Now, where do you get atrazine from? How does it get into the diet?
It's a herbicide that's sprayed on our food supply, and it's banned in Europe, but it's ubiquitous.
RFK was talking about this, wasn't he?
He was talking, I believe, about tartrazine, which is yellow dye number 5.
Yeah, we used to put that on our birthday cakes, I think, didn't we, when we were kids?
Tartrazine. Hey, little tartrazine, that'll make it prettier. Yeah.
Yeah, well, we didn't know.
That's an amazing video, by the way, his description of tartrazine and yellow dye number 5.
In all of the Cheetos and all of that.
Almost everything, even in medications, in asthma medication.
Color the pills?
Yeah, it's a liquid, but it's a yellow liquid medication, and the yellow is from this yellow dye number 5 is the cutesy name, but it's tartrazine, a coal tar synthetic chemical. So it's derived from coal tar. It used to be, but it's synthetic. It's made in a lab. And when you have 200 different synthetic chemicals in the body, circulating in our body, they will never be excreted. They will never be metabolized. They're part of the new human physiology. It shows up everything. It shows up in the cord blood of newborns.
Oh, wow.
And what did we just say? Oh, they're safe. Oh, you can have a limit of 3 parts per million of, say, atrazine. Where do they get that number from? They're making it up. I mean, these are just, they're shooting from the hip. And if they're waiting for their randomized control trial, you will never address these issues. But when you use deductive reasoning and logic and wisdom, and you can learn from individuals and examples and experiments in other mammals, you can actually learn. Learning is not only from the old randomized control trial model. It has its place in evaluating drugs and other clean interventions, but we can learn in other ways. And I think as a doctor, one of the most important ways we learn is from listening to our patients.
Mm-hmm. Yeah, listening. That I've been talking a lot about listening while Jordan and I are on the road with his books. How important listening is. Listening. There's no other way to learn, really. I mean, you can investigate. But even then you have to kind of listen, because you have to see what's happening when you investigate. And that's a type of listening.
I sort of go on listening tours. I get the opportunity, like you and your family, to travel, and it's amazing. And what's amazing is not the airline service and the free peanuts and soap in the hotels. What's amazing is you get to meet so many people with other life experiences who are sharing and educating me and you about what they are going through, what they're dealing with. One of the reasons I'm still practicing medicine, as much as it is challenging schedule-wise to do it, is because it keeps me grounded. I get ideas on medical research. It gives me a better understanding. And so not everybody can balance research and clinical work, but it is amazing for people who are willing to learn. It is amazing what you can learn out there. And right now on health, on the human condition, with podcasts, I mean, you can learn a tremendous amount. You can become an expert in certain areas of health and agriculture and in the environment just from listening to the right people. It used to be you have to go to the library and look up the right books and hope you get lucky. But now there are so many people out there educating folks, and we have a more educated population. A bunch of us are going directly to the public to talk about health. Casey Means, Peter Attia, myself, and I Prasad, members of your family. So people are now, we're democratizing education to the point where people who are motivated and self-driven can learn a tremendous amount of stuff. When I have residents and students, what I tell them is, what will make you a great doctor is not your knowledge base. It is your willingness to learn throughout your career and your humility to know your limits. When to say, I don't know, and that's the right answer. That was the right answer during COVID, by the way, a lot of times.
Right.
When to call for help when you need help. We are lacking. We have a massive deficiency of humility in the medical establishment today. And I think we're paying a heavy price for it. Mistrust is at all-time record high levels. 40% of eligible women for a mammogram don't get a mammogram. I mean, these are real issues that are affecting the health of the population.
And testosterone for men as well. You were talking about that in your book, that there's a lot of men who could use testosterone in their adult years and they're not getting it. They're not being prescribed.
Yeah, so testosterone, so hormone replacement therapy for perimenopausal women is the sort of much bigger effect size when we look at population health. Testosterone replacement for men with low testosterone levels and who cannot increase their testosterone levels through exercise and other means. There are health benefits there. The benefits are not as great as we see with hormone therapy in women with estrogen. We're talking about different hormones.
Yes.
In women, it's estrogen, often coupled with progesterone. But there's probably no medication that has improved or can improve the health of a population more, with the exception of antibiotics, more than hormone therapy for perimenopausal women. Cuts the rate of fatal heart attacks almost in half in some studies. Reduces the risk of Alzheimer's by 35%. Reduces cognitive decline by 50 to 60%. Reduces the risk of bone fractures if a woman falls. These are all long-term benefits, and people have misunderstood hormone therapy for perimenopausal women as symptom relief from menopausal symptoms like hot flashes. That is also true. It can alleviate some or all of those symptoms, but the long-term health benefits are incredible. And I go through all of them in the book, Blind Spots. Every woman should read it, especially women who have not yet crossed the 10 years after the onset of menopause time of their life, because you need to start it within the first 10 years of the onset of menopause if you're going to get those long-term health benefits. The vast majority of women are candidates. Some are not, but the vast majority of women, 50 million women, have been denied this incredible hormone replacement therapy around the time of menopause because of a dogma.
People were scared of it for a while, right?
Yeah, there's a guy from the NIH who claimed it causes breast cancer, and
that's right.
Floated that, and it really became dogma. When I interviewed him for the book, he acknowledged to me that there is no study, including his own famous study, that shows that hormone replacement therapy for perimenopausal women increases breast cancer mortality. Not a study. Yeah. And so it's ironic. Most of those 50 million women never got it for fear of breast cancer.
Yeah.
And the irony is, if it did cause breast cancer, the other benefits likely eclipse that risk.
So I went on hormone replacement therapy really during menopause. So like right away. I have older sister who's a nurse and another one who's a pharmacist. And so, they try to keep me in touch with what is good for my health. But then I got cancer and I stopped using it in 2019 because I got scared, right? And I just got rid of everything that had anything to do with hormones in my, just everything. And so now it's been 5 years and I haven't taken any. I wonder if I can start again.
What type of cancer, do you mind if I ask?
It was called a Bellini tumor. It was a kidney cancer.
I don't think that would be a contraindication. And even with breast cancer, there's a school of thought led by this oncologist, Dr. Avram Blooming, who says once the breast cancer is cleared, there's no more contraindication for hormone replacement therapy for perimenopausal women who are otherwise candidates.
Right. Okay. Well, that's good. I wanted to ask you that question.
Yeah, look into it. But if the doctor says a low-risk woman, a woman who has not had cancer, should not start it because it has a risk of causing cancer, and that is the reason not to start it, I think you want to find another doctor.
Right. Okay. Yes. Good. Well, it was very helpful to me when I started it. I never thought twice about it. It was just when I got cancer, I thought, oh, well, I'll just stop everything. But then I read your book. I thought, maybe that wasn't necessary.
Yes. Maybe it was not necessary.
Maybe it wasn't necessary. My dad had an ulcer, when I was a kid, a terrible ulcer, a duodenal ulcer. And we were in northern Canada, tiny little town with just a little airfield for prop planes, like really pretty remote. And he had a bleeding ulcer, and he had a type of blood that was hard to get, and so they had to fly him out. And I was just a very small girl because I can remember looking for my mother, and she was in her bedroom, and my sister was in her bedroom, and the doors were shut. And I was about the height of the doorknob, so I was a pretty little kid. And I thought, oh, where's my dad? Where's my dad? He came back in a couple of days, thank goodness. But I was very, very scared. And so I wondered about ulcers. I was into, children, when something like that happens, it becomes something important in their lives because something has almost taken their dad away. So they're not going to just forget about that experience. And since then, we have found that there's a bacteria that causes it. And is that something that everyone is aware of now? And is that how it is treated?
It's an amazing story. It's an amazing story. We used to do giant operations for these stomach ulcers and duodenal ulcers, giant barbaric reconstructions of the entire intestine, cutting parts of the stomach out and giving people these very morbid and disabling procedures that were high risk. And this was what general surgeons did just before I entered the field of surgery personally. I heard numerous surgeons talk about the stories of how this was a common reason why people were in the hospital having surgery. And then a doctor came along who said, you don't treat these with surgery, you treat them with a simple antibiotic. Because what's causing the ulcer is not stress, as the dogma said. It was not the type A personality or other things people had pointed to. It was a bacteria called H. pylori cured with a simple course of antibiotics, not these giant operations. And it's actually been known for a long time, but we just haven't had the humility to look at the research on this. The guy who really championed this or resurrected this concept of, hey, stop what we're doing. We need to treat a simple bacteria to cure people of ulcer disease. His name was Dr. Marshall, and he was an Australian who in the 1970s did a bunch of experiments, even at one point drinking this bacteria himself to give himself this sort of changes in the stomach and then cure himself with the antibiotic. He did everything, and people still thought he was crazy because the dogma was ulcers were caused by stress. This was a radical idea that it was a simple treatable infection. And he had a tough time getting doctors to believe his idea. He did all this research. He ended up getting the Nobel Prize. But to get attention on his research, he did what we all do in medical research, those of us who are researchers. He submitted his research findings to a conference to be presented in the form of an abstract. And this is the response he got from the conference where he submitted his research in 1983. Let me just read it for you here. Dear Dr. Marshall, this is the guy who ended up getting the Nobel Prize later. I regret that your research paper was not accepted for publication. The number of abstracts we receive continues to increase. And for this meeting, 67 were submitted and we could only accept 56. In other words, it wasn't in like the top, 80% of abstracts that they could have time to listen to. This guy ends up getting the Nobel Prize. This gets back to humility. Yeah, oops. This is what we're talking about, humility.
Yeah, that's for sure.
There's a lot of that stuff in medicine. I mean, when I went around to my colleagues here at Johns Hopkins Hospital and asked them for the purposes of the research on the book I was writing, Blind Spots, I said, I'm writing a book about medical dogma to try to educate patients on the latest medical truths that they are not aware of, that they should be aware of. I thought maybe I'd be able to pull 4 or 5 things here or there, It turns out like almost every doctor I talked to had a list of things in their little area of medicine within their specialty. And of course, I wanted to pick the things that are most relevant to the general public, that are the best stories, and that exemplified the different aspects of medical dogma going awry and causing tremendous damage. The power of groupthink turning into a herd mentality, even sometimes a mob mentality. We just saw it during COVID, railroading doctors who had impeccable credentials but disagreed or said things that the medical establishment found embarrassing. This sort of very headstrong approach to, we have the truth because we are the experts, even though there's no science. And it's done tremendous damage. This power of groupthink that I learned in doing the research for the book traces back to this psychologist, Leon Festinger. I'm sure you and your husband know know of him very well, the father of this concept of cognitive dissonance, describing how we love ideas to settle in our brain. Whatever we hear first, it becomes comfortable. It becomes nested in our brain, and we believe it. It's peaceful. We have one belief, and we don't have to wrestle with conflicting information. So we hold on to those beliefs for this purpose of comfort, of calmness. And then when a new idea comes along, when new information challenges our deeply held belief, our brain goes into conflict, and we subconsciously will dismiss new information to avoid that conflict. Mm-hmm. We will reframe new information to make it fit what we already believe, even though it doesn't fit what we already believe, just to get back to the calmness of having one simple belief. But that's not how science should be done. Science is about challenging deeply held assumptions. But we are all susceptible to this trend. It is part of the human condition. It is why if someone smokes cigarettes and a study comes out showing that smoking kills people, they will automatically, subconsciously go into this mode where their brain will think, well, that study was done in different people. I don't smoke as much as the people in that study probably did. I use filtered cigarettes. They probably didn't use filtered cigarettes. I am exercising, and that's probably counterbalancing the harm of the cigarette. And the brain will go through acrobatics to justify holding on to what we already believe for the calmness of having that one belief. It's also known as the founder's effect. We believe what we hear first, not because it's more logical or scientific than new information, but simply because it settles first. It's why people don't change political parties from their parents many times, or even when new information challenges their political views on both sides. It's why management can make very stupid decisions despite having a lot of smart people at the top. It affects relationships. It reflects medical science as well. This is a part of the human condition that is really the physiologic scientific basis for groupthink. And it explains a lot of groupthink in medicine that I write about in the book Blind Spots.
Yeah. And as you say, humility, it's a frame of mind that is lacking humility.
Right? Yeah, when you add pride to that cognitive dissonance, can be a deadly force. I mean, have you heard any of the public health officials during COVID apologize for shutting kids out of school for nearly 2 years, or any other, the not allowing people to visit their dying loved ones in the hospital for 2 years? All of them, all the hospital leaders, all of them. Groupthink in lockstep, all the hospital administrators in North America locked arms and walked off a cliff together in solidarity. We cannot allow people to visit COVID patients. Doesn't matter if it's your soulmate or mother or father. We cannot allow you to go in and take that risk, even though you're willing to take the risk.
Yeah.
It's an old culture of paternalism in medicine that really crosses over a lot of stuff. I was just talking last night to I went to the Baltimore Ravens football game, which
who won?
A colleague of mine who's a breast cancer surgeon and I.
Oh yeah.
And so we were talking afterwards a lot about the field of breast cancer and why it's going up and what's going on. And so it's amazing. We have a tool called mammography, but a lot of women don't want to have a mammogram. It's uncomfortable. There's radiation, and they may be uncertain about the impact of the radiation long term. The recommendation just moved from 50 down to 40 in low-risk women with no real good clinical trial support for it. So 44 out of 10 women have basically said no thank you to mammography, who are candidates and should get a mammography. So this is a massive failure in screening. Now, there's another test that is not a mammogram. It's not radiation. It's not uncomfortable. It's not compressing, a sexual organ. like a mammogram. It's an ultrasound. It picks up 90%, maybe more, of the lesions a mammogram would pick up. But we don't recommend it for the 40% of the women who don't get a mammogram. We don't talk about it as an initial screening tool test. Why? Because the women who are not getting the mammogram are disobedient. They are bad and they need to comply. And it's this paternalism. It's this lack of being practical, a lack of listening to people about what they're saying and what their concerns are. And so it's just a fascinating thing. And we were talking about, should we be more open and honest about ultrasound as a screening tool for breast cancer, recognizing there's 10% of lesions you're not going to capture that you would on mammography. But can we be pragmatic? Can we save more lives by using common sense?
Yeah, that's a great idea. I think that sounds like a great idea, because people are pretty on board with ultrasound. And my nephew, who's a rheumatologist, his specialty is ultrasound now. And when I was in the hospital, I had an IV that went wrong. The pick wasn't in the right place or something, and it started to swell. And I was on an elevator, and this doctor pulled this, it looked like a pager or something, out of his pocket. And it was an ultrasound. And he ultrasounded my wrist, like just as we got off the elevator. He goes, "Oh, no, you have to have that needle put back in because, it's not in the right place." I'm like, wow. Ultrasound is become very available. And so that would be a good idea. So what do you think of fluoride in water? And what is it doing to everybody? Do you know?
I have serious concerns about the unintended consequences of fluoride added to drinking water. Yes, it reduces cavities slightly because it is what we call bactericidal. That is, it kills bacteria on the teeth. Mm-hmm. But if it kills bacteria on the teeth, what do we think it's doing to the microbiome, the lining of the gastrointestinal tract, of millions of different types of bacteria? Those millions of different types of bacteria are not just sitting there, they're busy. It is a central physiologic organ. They are involved in digestion and absorption, producing vitamins, regulating hormones like estrogen. Some of those bacteria even produce a little bit of Ozempic naturally. They produce a little GLP-1.
Oh, yeah.
They train the immune system. They make serotonin. They make most of the serotonin in somebody's body. Serotonin is involved, of course, in mood and mental health. So what are we doing? We're carpet bombing the microbiome in the modern era with unnecessary antibiotics, with ultra-processed foods, tons of sugars and concentrated sugars, pesticides. I mean, if pesticides kill insects, what do we think they're doing to that delicate balance of bacteria in the microbiome? And I think fluoride is also having some effect on the microbiome that we don't fully appreciate. And Europe doesn't do it. Europe, 3% of the water has fluoride in it. Canada, it's about 30% of the water. In the United States, it's most of the drinking water. Now, if you go, and that's all separate from another concern that has been written about in one of our top journals called JAMA, Journal of the American Medical Association. These are not fringe studies showing a lower IQ among children born in fluoridated water areas. There's some concern that it may build up in the learning center of the brain. There's other health complications that have been associated with fluoride. So what are we doing? The CDC has made this a sacred cow issue. You're not allowed to discuss it or ask questions. If you go to the CDC website, it is listed as, no joke, one of the 10 greatest public health achievements in modern history. That's on the CDC website. They have a list of the 10 greatest achievements in public health in modern history. So
pride. There we are with pride.
Pride.
Oh dear. I guess that my last question would be, because I think we're almost running out of time, is gender affirming care. I want to talk about that a bit and how that has become something that doctors have been leading the charge on, is gender affirming care, and what it's done to our young people, not just our young people. My husband came home last night from Nashville. He was doing a new podcast idea where he answers the call. So people call in and he does clinical psychology like that. So I think that's very good for him because he misses his craft, And he said there was one young fellow who came in, and I said, and then they did family therapy, but it was really like husbands and wives. I said, were there any children there? Well, there was an 18-year-old kid there, and he was upset because his grandmother last year changed her gender. Last year, his grandmother. I'm like, what? What?
It really, I think, relates to some of the themes we've discussed in our discussion today. The creation of sacred cow topics you're not allowed to question. The power of groupthink. The canceling of ideas that some in power don't like. And so it's very hard for there to be true civil discourse in the medical community among experts on this topic. Take, for example, the American Plastic Surgery Association a few months ago made a bold statement to say, look, this is low quality and a low level of evidence to support these types of medical treatments and interventions. Now, this is an association of doctors who are doing these procedures, or at least the same specialty. They came out with this bold statement that went against the current of what a bunch of other medical associations, many of which have become very political, but what they have said as position statements on it. Well, within a matter of a month or so, the activists descended on the leaders of this organization and got them to change their position.
Oh, wow.
So there's not a civil discourse on this topic. And separate from the merits of both sides of the argument, we have a cancel culture in the medical culture on this topic. And I can tell you a lot of doctors I know are afraid to talk about it. They are afraid to say anything public about it. I have not been, as you may or may not know, that I hear statements from the Assistant Secretary for Health that gender affirming care, in the way that she defines that, is really talking about puberty blockers and surgery. She's not talking about counseling and talk therapy. She's talking about...
I know, it sounds so benign, eh? Gender affirming care.
Care? Who's against care? I mean,
right.
Care is a good thing, right? So she says that gender affirming care is suicide prevention. Now, she made that bold statement.
She did, huh?
I would love that to be true. Show me the data. Show me that study. Does not exist. Does not exist. Matter of fact, studies that have come out since that claim have suggested that it is the underlying psychiatric diagnoses that are driving the suicide risk and not the gender dysmorphia diagnosis itself. And so...
that sounds true.
It's a very difficult topic. I think there are, I'll give you a perspective you may not typically hear out there. I think there are two extremes on the issue. There are children born with what we call differences in sexual development. It used to be called intersex. There are people with genetic changes, missing an X chromosome, so they just have one X, or they have an extra X and they have a Y. Turners, Klinefelters, they can have real gender identity confusion. This is a medical condition that should be recognized. There may be a role for some sort of medical intervention in that population. But what's happened is now you have two extremes where it doesn't exist, or we have to encourage everyone to explore what their feelings are at age 9 and call them by what they want to be called. And then if they change their pronouns every day in class, which one child has done, then the other children have to change the pronouns they use every day. So it's a lot of work. Every day that this child changes their pronouns.
Not a lot of time for math, hey?
Yeah, and where's common sense, right? Like, where the child may be struggling with gender confusion, as many or most children struggle with gender identity or confusion at some point to some degree in their childhood.
Yeah, well, I remember when I was first, I was a tomboy. I really loved to play baseball and skip, and I was outside all the time riding my bike. And when I started to go through puberty, I was like, what? What's this? My body's changing. And it was a shock, right? It's a shock. And it was a shock, and I was, well, I wondered what I should do about it. Well, what you should do about it is go buy a pretty lacy little bra that you put on, because that's what you do. And hopefully you're encouraged to do that, because that is the kind of a rite of passage is that. And it is surprising, and it is a little bit confusing, and might color your mood as well. But that doesn't mean that something as radical as transforming yourself from a girl to a boy is necessary. It's just not. And I know I've interviewed people too who've been traumatized as young girls. Maybe they've been sexually abused, and then they don't want to turn into women because they don't want any men coming after them because they're afraid. Well, unfortunately, you've had a trauma, but that's what people who love you are for, is listening, to listen to you and to listen to your troubles, so that you can realize that everybody has troubles, but we get through them with the help of the people who love us, to put their arms around us and care for us and help us through these terrible traumas that all of us have to go through now and then in our lives. But deciding that we're going to run away from who we are and become someone else, that's so dramatic. It's so dramatic, and it's so costly that it's not something to be investigated and just decided at the flip of a coin that that's what you're going to do. Yeah.
I don't know if you heard that in California, there are inmates in male prisons who will state that they are female one day.
Yeah.
And then without any question be transferred to a female prison where there have been reports of cases of sexual harassment.
Yeah, I know
and
that.
at what point can somebody say, this isn't right? This isn't right. And right now, we do not have the civil discourse on this topic. We've created a sacred cow type of dialogue where. Mm-hmm. So anyway, thank you, Tammy, for what you're doing and your whole family. I enjoyed getting to know your whole family as we had dinner before that historic day. Mm-hmm. So it is really a pleasure to know you.
This has been lovely, and I hope that we can get together again soon. We're going on a book tour again through the States. We'll be on tour till April. So hopefully we'll be somewhere near you and we can get together.
Great. Well, I'd love to see you, and send my best.
I will.
Great. Thanks so much, Tammy.
Thank you.